All right. Well, great. Well, welcome everybody to the regional session here at the Huntsman Cancer Institute. As you know, probably from earlier today, my name is Laura Lambert. I'm one of the surgical oncologists here. My partner, Dr. Erin Ward, who was planning to be here, unfortunately had to go to the operating room today, so she is not going to be able to attend, but she is with us in spirit. And I'm delighted to have Ariel Mirendorf, who's going to share her story about PIPAC and her journey with appendix cancer on the call with us here or in the symposium. But before we do that, I thought I would do a little. I know we just heard all about PIPAC from Dr. Raouf, but I thought I would just share a brief presentation just to kind of maybe break it down a little more simply and talk about just the details, the what, why, where, and when for PIPAC. So I'm going to go ahead and share my slides here with you. Let's see if I can figure it out. Here we go. All right. There we go. All right. So, and if anybody has any questions, just please put them in the chat, and I will definitely try to answer all the questions. I think we have kind of a small enough group that we should be able to address all the questions that people have. And if you have questions from the symposium that didn't get answered, I'll be happy to do the best to answer those questions for you. So, so PIPAC. Let's see here. So what is PIPAC? So HIPEC stands for hyperthermic or heated intraperitoneal chemotherapy. PIPAC stands for pressurized, meaning the chemotherapy is delivered under very high pressure, which causes it to become aerosolized. And so it's pressurized intraperitoneal, meaning given in the abdominal cavity, aerosolized. So it's like an aerosol, like, if you use hairspray or something else like that, it's an aerosol. Chemotherapy. As Dr. Raouf described, this is a minimally invasive procedure. So what that means is it's all done laparoscopically. So with the camera and the little tiny incisions for the other instruments, it's given directly, and the chemotherapy is given directly into the abdominal cavity at the time of the procedure. It's relatively new methods, especially here in the United States. It's actually been around for quite a long time and just slowly evolving in terms of our understanding of the safety, of what its efficacy will be, which people might benefit the most from it. And as Dr. Raouf was describing, it can be used not only to try to treat the cancer in the abdominal cavity, especially if it can't be removed by surgery, but also hopefully to address symptoms that somebody might have and even help and control like the fluid buildup, or ascites is what that's called. So there's a number of different chemotherapies that we can use. As Dr. Raouf said, he's used oxaliplatin, mitomycin, cisplatin, and doxorubicin. These have all been used extensively in Europe and now in the clinical trials here in the United States. And again, just like HIPEC, what it does is basically it allows us to give a higher concentration of the drug directly in the abdominal cavity where the cancer is. And because it's under pressure, that drives the chemotherapy more deeply into the tissue to help try to treat any cancer that's there. So there have been a number of studies that have looked at the efficacy of it, trying to get a sense of what we call an objective pathologic response rate, meaning that after somebody has had the treatment, the surgeons have gone back, done another biopsy, the pathologists have looked at it under the microscope, and they're actually seeing that the area is now just scar tissue, or there's no more cancer cells. Or in somebody who has a CT scan where you can readily see the cancer, you're seeing it responding to the treatment, or somebody who is symptomatic, their symptoms are getting better. And so you can see it varies depending on the type of cancer, how effective it's been in the study. And there has been some reports of improvement in overall survival from 6 to 8 to 16 months. In addition, that means not just that the survival is 6 to 8 to 16 months. It means in addition to what the normal overall survival was, this is adding an additional 8 to 16 months depending on the tumor type. Phase 1 and phase 2 trials, if you're not familiar with those terms, clinical trials are done in what we call phases, phase 1, 2, and 3. Phase 1 is a trial where the people who are doing the trial are just looking to see if the drug is safe and or the treatment is safe, and to try to determine the level at which the drug or the treatment becomes unsafe, so that they're not looking for any effect of the treatment. They're just looking to prove that it's safe and to try to identify a dose, if the study is looking at a drug, that can be used in future clinical trials. Phase 2 trials are then taking that drug or treatment and now looking to see, you have the dose that you want, that you know is safe, the maximum tolerated dose is what we often say. And now we're looking to see, does it actually work? Is it actually treating the cancer in the way we hope it will? Phase 3 trials are what you've been hearing a lot about, randomized control trials, where their patients are randomly separated into different groups depending on what the treatment arms are, and then they're compared. So you're comparing this new treatment that you've proven seems to be effective in a phase 2 trial, is safe from a phase 1 trial. Now you're trying to compare that treatment to like the standard of care. Is it better than what we're already doing? And that's considered to be the gold standard of determining whether a treatment should be offered to everybody outside of a clinical trial. And so in the studies that have been done so far, the phase 1 and 2, we have seen encouraging pathological response rates. It appears to be safe, and there appears to be maintenance of quality of life in selected patients with refractory peritoneal metastases. And that refers to the study that Dr. Raouf talked about, where they looked at the number of good days comparing people who got just intravenous chemotherapy alone versus those who are able to get PIPAC. And right now we're moving into the phase of phase 3 studies, so we can see if this is going to be effective, like better than the regular treatment, the conventional treatment that we have. So who is eligible? Really, essentially anybody with who has a disease, a cancer that's causing peritoneal carcinomatosis, meaning spread of the cancer through the abdomen, so obviously appendix tumors, but also gastric or stomach cancer, colon cancer, mesothelioma, and ovarian cancers. And the what we're looking for, particularly with appendix cancers, is this is being reserved right now for people who it's not felt like they're a candidate for the cytoreductive surgery with the HIPEC. If a person can have cytoreduction and HIPEC, meaning we can do a surgery to try to remove all the cancer and treat with the HIPEC, that would be the preferred choice. But there are times and situations where we find out that the disease is involving too much of usually the small bowel or small bowel mesentery. That's the apron or the sheet of fat in which the blood supply to the small bowel lives. And that's an area that's very hard for us to clear surgically without what Dr. Levine called leaving people with a short gut syndrome, with not enough intestine to maintain their nutrition. So we can't take out all of somebody's small bowel. So if that's the situation and the person's not a candidate for cytoreduction HIPEC, that's when we start to think about, would PIPEC be an option? So that's this, you've seen some of these pictures or diagrams. So basically it's done laparoscopically. So the patient is under general anesthesia. There's just a couple, 2 or 3 laparoscopic instruments that are used. The abdomen is distended with carbon dioxide just for like regular laparoscopic surgery. And then there's a special nebulizer or pen that you can see down in the right lower part of or the left lower part of the screen here, where there's this metal device that the chemotherapy comes through. It's connected to an injector. It's the same kind of injector we use for giving contrast for a CT scan, but it's under much higher pressure. So when that chemotherapy comes out, it's aerosolized. And because the abdomen is inflated with CO2, it generates pressure that then drives that aerosolized chemotherapy into the tissue and into the tumor. So that's what it kind of looks like there. During the time of the procedure, so these procedures are usually about 30 minutes. Chemotherapy is given in about 5 minutes, and then we let it dwell for 30 minutes. During that 30-minute time period, believe it or not, everybody in the operating room is out of the operating room. We're standing close by. We're monitoring the person through a window. Even the anesthesiologist is outside of the operating room with us. They have ready access to get back in within seconds if they need to. So it sounds kind of odd to have everybody out of the room, but it's safe. There are a lot of safety protocols around that. So that's one of the reasons why it's been a little bit hard to get it up and running more in the United States, is there's a lot of concerns about safety for staff and for the patients as well. So it does take a lot of convincing and some negotiating with hospital administrators to get this approved in different hospitals. This is some, sorry, these are some pictures from the OR, where you can see, so on the bottom here, these are the laparoscopic instruments going into the abdomen. This is the monitor here showing the drug going in. This is the team standing outside the OR watching everything on a monitor so they can see the chemotherapy being given. And this is just some more of the devices in the operating room over here. This is the clinical trial that Dr. Raouf mentioned, looking at mitomycin in combination with intravenous fulfuri for appendiceal or colorectal cancers. This is still as a randomized phase 2 trial, so it's still looking mostly at efficacy. So the primary outcome, like he said, is going to be progression-free survival. So that means the question that came up in the chats earlier is like, how do you measure overall survival? When does the clock start? In a study like this, where you're looking at progression-free survival, the clock is going to start with the first PIPAC, and then they're going to monitor going forward. How long does it take before we see any evidence of the cancer progressing? So that's the primary outcome. Then the secondary outcomes will be overall survival. So how long does a person survive or live after they get the first PIPAC? And then the study also involves a lot of other ancillary studies looking at the tumors themselves. How are they responding to the chemotherapy? Looking at the blood, looking at peritoneal fluid. So a lot of other studies to really understand what the impact the PIPAC is having at the tumor level as well. So I'm going to stop there, and I'm actually going to turn the microphone over to Ariel. So, and I'll let her tell the story on her own words. So go ahead, Ariel.
Thank you, Dr. Lambert, and thank you, ACPMP, and just a privileged person to be able to have treatment both from Dr. Raouf and Dr. Lambert. So I was diagnosed with stage 4 high-grade mucinous adenocarcinoma of the appendix just over 4 years ago. It was in July of 2021, and was moving towards HIPEC, as many of us do, wanting to see if we qualify for the HIPEC procedure. Started out with chemotherapy, the FOLFOX chemotherapy for 12 or 13 rounds, and then myself and my family ended up moving from Arizona to Utah to be seen at the Huntsman, which is where we live now in Utah, and had my laparoscopic exploratory surgery to see how effective the 12 rounds of FOLFOX was. And we decided that there was too much involvement in particularly the small intestine and the mesentery to be a candidate for HIPEC, which is when we started looking at options for clinical trials. And we got in contact with Dr. Raouf at the City of Hope in LA. And the most difficult barrier in getting there to the point where I could receive that procedure was the insurance back and forth. With being insured in Utah and getting this approved in California. There are insurance loopholes that allow if there's procedures that can be seen as the last in line procedure if other procedures aren't available. There are clauses that say that insurance is required to cover these, and so it took a lot of advocacy from myself and my family to get that to go through, and that was a months long process. And once I was finally approved for it, I flew out to LA to have my first PIPAC procedure done, and we stayed in that area for a few weeks after surgery so that I could be monitored more closely as we didn't know kind of how I would respond. I would say general complications, post-surgical complications, pain, fatigue, and then a tightness and bloating that lingered for weeks, especially after the first procedure. And then after the second, so then 6 weeks later, after the second procedure, I did have more complications with extreme pain and nausea, and was able to be hospitalized a few times and get on TPN IV nutrition to help me keep my nutritional intake going, as I was having a hard time keeping down foods. Overall, I would say, compared to what I know with my friends who have done HIPEC, the recovery was shorter. It was short and intense for a few months, but with slowly incorporating foods again and moving more, I was able to recover what I felt like fairly quickly within a few months. Um, yeah, so super grateful to have had that option. And I think so much goes into the mental side of it with cancer treatment. Just knowing that you have options can provide so much hope. And when people have hope to hold on to, that can do so much for healing, I think. Just knowing that there's more options for medical care out there for folks in this unique population.
Great, thank you, Ariel. Can you share a little bit more? I know that I think I read about your story in the press, right? Like what how did that come about? I know you had to advocate really hard for this. Can you tell us a little bit more about that aspect of it?
Yeah, sure. So the initial request to have this procedure done was instantly denied by insurance, and we had to ask for multiple appeals, and I was given multiple different reasons as to why it was being denied, reasons that were oftentimes indicated like contradictory.
Yeah,
And so I think for many folks who don't know the level at which you have to advocate, you might just say, oh, it got denied, and then they hope that you move on your way. And luckily, I come from a family of folks in the medical field who know how to continue to push and make things happen. And so we had to push it to the point of getting in front of a judge to appeal to a judge and bring the heads of our insurance into that court and into that meeting. And I had to get approval letters, both from you and Dr. Raouf, explaining why the procedure was necessary for me. And again, it was sort of like there were these hoops I had to jump through, and it felt like they continued to change the hoops. And once I jumped through that hoop, there was a new hoop. And so we did that dance for months while I was still, just receiving kind of maintenance chemotherapy every other week, and had to really share my story and pull on the heartstrings. I'm a single mom. I was diagnosed at 30, a week after my 30th birthday. My son was 18 months old when I was diagnosed. He's now 5 years old. And I just have so much to live for, and so much to continue to fight for. And so had to really continue to push everyone involved and keep a really good record of everyone who I contacted with my insurance so that I could use references to the fact that I had to jump through so many hoops in order to get to the
Mhm.
place that I was. So,
Mm.
yeah.
Well, I'm glad you were able to do that and that you had the support you needed to do that because it's like adding insult to injury when people who are dealing with a life-threatening cancer diagnosis can't get the care that two experts in the field are recommending, right? And you have to, it's just crazy that you have to do this dance, like you said, to just get what you need to save your life, you know? Yeah.
Yeah, and I think it's important to mention that there are advocacy organizations out there, both that can help with kind of the medical side of it, as well as potentially travel or lodging. We read a book called The Insurance Warrior about how to navigate insurance in these cases when things are getting denied. And so we definitely had a lot of other support too outside of my family that contributed um, to making it happen. So there's definitely organizations out there, even through insurance companies or through the hospitals. There's navigators that um, are make it their mission to make things happen for patients. It's just a matter of reaching out and finding those people.
Mhm. Yeah. I'm glad you mentioned The Insurance Warrior. So the author of that book is Lori Todd. I don't know if you actually met her or talked to her, but if anybody is finding themselves in a situation where they're dealing with these kinds of issues, either pick up the book or just Google Lori Todd, Laurie Todd, Todd, or Insurance Warrior, and you will find her. Her book is incredibly helpful and instructive, and she also offers consultations to help people get things approved that we're struggling to get approved. And one of the things that she always talks about, and that you've illustrated here, is that a lot of people think it's like the doctors have the most say or influence on insurance companies, but in fact we don't. And one of the best things, the thing that probably helped, one of the things that helped you probably the most was humanizing it, right? And giving them a face and a name and a story and making it personal so that they weren't just denying based on some policy or this is experimental, but they were actually denying a person this opportunity to be treated. So if anybody is in a situation like that, I definitely recommend reaching either or looking up Lori Todd or reading her book or reaching out to her as well. So, and like Ariel said, there are a lot of other resources as well for support. Um, is there anything else that you would suggest to people based on your experience with appendix cancer, things that you wish you had known as you were going along, places where you found other areas where you found support that were helpful?
Yeah, I'm part of an organization called PMP Pals, and they're really focused on the social emotional side. That's a big part of what they do, and they do things like sending encouraging letters to folks who are recently diagnosed or who are going through a hard time. They send care packages and bears and blankets to folks who are in the hospital, and most importantly, they have twice a week Zoom calls with other people who have the same pathologies as you and who are at all different parts of their journey. There's folks who show up to the meetings who are survivors of years and years, and then there's folks who have just recently been diagnosed, and everyone in between. And so that's been a really important um, organization for me to get connected with, especially in the beginning, just not feeling so alone. There's so many emotions, obviously, that come into play when you're diagnosed with a rare disease, and it can feel extremely isolating. And just to be instantly connected with folks all over the world who can resonate with how you maybe felt totally healthy before you were diagnosed, or how the side effects of chemo can really be weighing you down. Everyone has walked the path. And so that has been a really influential organization. And, other folks who, and other types of cancers, they just don't get it always. Like every cancer is totally different. And even within the appendix cancer world, people with low grade versus high grade cancers are treated so differently. So really reaching out and leaning on other folks who have, the same exact pathology as you can be super helpful. Yeah, and then just asking for what you need, that can be so difficult for folks in today's world to just be in a state of having to receive and being okay with asking for what you need and allowing others to give and pour into you and trusting that there will be a time again when you can be the one to pay that forward and give back. I've certainly been through I think so many ups and downs, and I'm still very much on my healing journey. I'm still monitored, and although I have no evidence of disease right now, there's still always that anxiety and worry of what could happen with the next CT scan. And so um, yeah, just really leaning into what feels like it heals you and nourishes you, and knowing that it's okay to feel the full span of emotions, and there is hope for the other side of this, and hope for life to be so awesome. I feel better than I think I did before my treatments. And so just want to put that out there that it is totally possible to come back feeling stronger and better and more healthy and more vibrant than before. And sometimes that's hard to remember when you're in the thick of it.
Yeah, very much so. Yeah, thank you. I think that was, I'm sure that resonated with a lot of people on this call. That feeling, initial feeling of isolation. And then when you have this rare cancer that people are looking at you like you've got three heads, right? And they have no idea. And then hopefully you find somebody who has seen a lot of it, who can give you some sense of place in the universe, right? I think that's the other part that I find that people are struggling the most, is when there's no clear plan, right? Like you've got this diagnosis, but you don't know what to expect next or what the potential outcomes are. So finding, somebody who is an expert in this field that can tell you where you are in the universe in terms of this disease and how things are going to go, and help you come up with a plan, and then help you feel supported. I'm really glad you mentioned the PMP PAL. So when I am meeting people for the first time, I will often ask if they've been online. And then I will say there's really two websites or organizations that I feel are safe, and I will definitely give people the ACPMP Research Foundation information, and then also the PMP PALs. And like you said, their area of focus primarily is in support, and they do a terrific job with that. And both groups have excellent sources of like educational material that I think is safe. And one piece of advice that I was given by a patient was to tell other patients to not go on people's Facebook pages or their personal like websites, because things can get scary and you don't know all the details. And a lot of times people are posting the negative stuff, and then people like yourself who are back to work and doing all the things that you want to do and running around, chasing after a 5-year-old, you're not posting as much because you're doing other things, and not that. So a word of caution, for people who are looking online. And I understand, in this day and age, that's where we go to, right? Like we Google, and as soon as you Google appendix cancer, if you don't know exactly what you're looking for, it can get very scary very quickly. So please, my recommendation would be, before you do that, before you dive into Google, find an expert in the field who can give you some context, and then help guide your searches and your understanding. I'm not saying don't look up information. I think that's helpful too, but you want to make sure you're looking up the right things about your condition. So oh, that's great. There is a question in the chat. Let me see here. And please put your questions in the chat. So if there's any questions about anything related to PIPAC or other parts of the symposium, or just in general, we'll be happy to try to answer those for you. So the question is, why is PIPAC used overseas more frequently than in the United States? That's a really good question. It seems like a lot of these more pioneering types of approaches to treatment of any kind of disease, cancer or whatever, tend to come from Europe first. I suspect it has to do with less regulation over there, so it's easier for them to get devices approved, to get the treatment approved, and then to start doing, the phase 1 studies and then ultimately the phase 2 studies. So they are literally decades ahead of us in regards to PIPAC. They've been doing it for a very long time. And it's only been recently that in the United States we've decided to I guess we kind of waited to see, like, is this just gonna come and go? Is it going to be a humbug, or is this something that really offers some opportunity and we should pay attention to it and start doing it ourselves? And then doing it more formally, like in the context of clinical trials. So one of Dr. Rauf has been one of the biggest advocates for not letting, just like putting the cart before the horse and letting the floodgates of PIPAC open, so that we've got all these centers across the United States who are doing it just ad hoc and for whatever reason, and then people are getting hurt or not getting any benefit of it, and we've lost control of how to study it. So he's been a real advocate of that. It should be done in a controlled fashion, specific circumstances, specific patients. Let's study it thoughtfully. So one of the things that happened with HIPEC was it kind of just got going, and there was just, everybody was doing HIPEC whenever they thought it was kind of the right thing to do. So it took decades for us to really figure out how to do good patient selection, kind of figure out what really was helpful, what's not. The techniques for the surgery evolved during that time. And so, but we were kind of stuck with going back and looking at, databases retrospectively of HIPEC experiences at different institutions. And it was all over the map, different types of chemotherapy, different lengths of time, different tumors, different, surgical cytoreductions. So it's hard to then really figure out exactly what's going on. So that's why he's really been a proponent of doing this thoughtfully, is putting forth these clinical trials. The insurance companies are not covering it outside of a clinical trial. The pens or the nebulizers have only just recently become FDA approved. So it is happening in a more controlled fashion than it did in Europe or than HIPEC did in the United States. So a couple more questions. Is PIPEC a treatment option for patients that have already undergone HIPEC and the disease has recurred? So yes, that would be a potential option. I think one of the things I did not mention was that at PIPEC, there's no surgery that's done. So this really is reserved for the situation where the cancer cannot be completely removed and HIPEC is not going to be beneficial. If that's the case, if there is an option to remove all the cancer and do another HIPEC, that would be the choice. But if not, if the cancer comes back and now this time it can't be removed completely and the person is getting chemotherapy, then if that meets those criteria for that clinical trial, then yes, you could do a PIPEC after a HIPEC. At some point after a HIPEC, that's absolutely a possibility. So having a HIPEC does not preclude you from somebody from getting a PIPEC. And then the next question, can additional rounds of PIPEC be done again down the road for a patient like Ariel who has had success with it if the disease returns after several years? That's a great question too. I don't think we have any data around that just because it's so relatively new. And we don't have a lot of patients like Ariel who would, be in that situation yet. But if that was the case, I do think, again, we would first assess that person to see if we could do cytoreduction and HIPEC, and that would be the first choice. And if not, then if PIPEC was an option, that would be, you could do more PIPEC in that situation. So, let's see. I think that gets all the questions there. Any other questions from the group here? Or I can see if I can answer some of the pre-submitted questions that we didn't get to. Where should one diagnosed with LAMN, T4, N0, right hemi with lymph node removal February 25 diagnosed, proceed, no current PMP. So, the question, to answer to that question, so this is a low-grade mucinous neoplasm that had a in the setting of a right hemicolectomy. So no surprise that there were no lymph nodes positive, because the LAMNs cannot spread to the lymph nodes. As long as there's no, if there was, the answer to this question would depend on if there was perforation of the appendix seen on pathology. If that was the case, then I would recommend, if there was perforated, I would recommend surveillance. I would recommend with CT scans. MRI are an option, but like Dr. Olpen said this morning, if you're going to do MRI, it does require a specific protocol for the MRI with the diffusion weighted imaging that he was describing. And you really need a dedicated abdominal MRI radiologist who has an interest in reading these types of films. So that can be a little bit of a hurdle. You really want a good radiologist who's interested in looking for mucin on these films. Otherwise, CT scans are perfectly fine. And again, with this particular diagnosis, if there was a perforation and any concern that it might recur in the peritoneal cavity, it would be every 6 months for the first 2 years, yearly out to 5 years, every other year out to 10 years, with CT scans and tumor markers. So we usually recommend that everybody have tumor markers. There's 3 tumor markers that we follow: CEA, CA125, and CA19-9. Those are the 3 that we follow, and we get those with the CT scans. So that would be, without knowing more, based on this question, that's what I would recommend, is just surveillance at this point in time. I would not recommend like a prophylactic HIPEC, meaning you're going in, you're doing HIPEC to try to prevent recurrence. There's a really good likelihood with this type of tumor that you will never have a recurrence, which would be great. And you don't want to have a HIPEC unless you really need one. So yes, we can get people through them safely, but in as much as we love to operate, we don't want to operate unless there's a real indication for it, and we think the person's going to need it or benefit from it. So, I think Ariel's answering the next question. Doing a maintenance. Did you do maintenance chemotherapy after PIPAC?
No, I didn't do maintenance chemo after PIPAC. All of the biopsies that they took as part of the study when they were going in to do the PIPAC surgery, the biopsies were coming back negative. After that initial spike in my inflammatory markers in the blood test went down just from surgery, they maintained normal levels. So I had no indication of disease based on biopsies, based on blood markers, and then no new or visible growths through CT scans. So using those 3 ways of tracking, I technically had no evidence of disease. And I know my oncologist had spoken about the potential of doing maintenance chemo. I always say I've never been sick with cancer. I've only been sick with chemotherapy. So I wasn't super inclined to do maintenance chemo if there didn't feel like evidence for doing it, and my oncologist kind of agreed, and he's really taking a collaborative approach with me, since he doesn't have any other patients who are in my position who had been through the PIPAC procedure. So I'm lucky to be able to work collaboratively with him, and I'm just monitored very closely. But no, I haven't been on any chemotherapy since my last PIPAC procedure, which was 2.5 years ago now.
Yeah. Well, I'm glad you brought up that point too. I really hope that everybody who's dealing with this type of cancer can find somebody who's willing to work collaboratively with them, because it is not uncommon that we find ourselves in uncharted territory, right? And really, in my opinion, that's when it really should be a partnership where the physicians are providing you with the best knowledge and information to help make decisions. And there's not going to be as much, we have the guidelines now, but it's easy to quickly fall off those guidelines and to find yourself in uncharted territory. And the right next step is different for everybody, right? Depending on your life circumstances and your goals of care and symptoms and the treatment you've been through already and the type of cancer that you have, all of that has to come into play. And ideally, you are, working with somebody who's willing to take all that into consideration and partner with you and really just kind of work together as a team. So I'm glad to hear you have found that, Ariel, and I wish that for everybody as well. Yeah. So next up, is another question. Diagnosed with a lamin after an appendectomy and right colectomy with a T1 classification, and was not offered any observation in the future. Do I need to be followed? I would say no. I say congratulations. You're lucky you got your appendix out. If it's a T1 tumor, there was no perforation, zero, and it's a lamin, zero risk for lymph node metastases. If it hasn't perforated, zero risk for recurrence in the abdominal cavity. And I have to say, I love seeing people in this situation in my clinics. I occasionally I get this. Somebody gets referred to me by a general surgeon because general surgeon's really not sure what to do next. So they come to see me. And those are some of the happiest visits. I get to walk in and just talk to the person about their appendix tumor, and tell them they're cured, right? Like, so you were lucky that you got your appendix out when you did, and you don't have to worry about this. So that's wonderful. Congratulations. Next question is, what disqualifies someone from receiving PIPAC? So there are some contraindications, if you will. So obviously, if the tumor has spread outside the abdominal cavity, that's an obvious one. For the clinical trial, then there are some specific ones to the clinical trial. So for this clinical trial that Dr. Raouf was talking about, a person has to be able to get this chemotherapy called FOLFIRI, and they can either be starting it or be on it, but not having their disease progress. Then there's some where there are some evolving relative contraindications. So one of the things that we know is that the bulkier mucinous tumors tend not to respond as well. I think it's kind of probably easy to imagine why. Again, those big bulky mucinous tumors are mostly mucin and not cells. The chemotherapy that's being put in is really designed to kill cells, cancer cells. And so if those cells are if there's a handful of cells entrapped in all this big bulky mucin, the chemotherapy is not going to get to those cells and it's not going to treat the mucin. So that's not been as effective in that setting. The other area, which is a little more subtle, is again involvement of the small bowel and small bowel mesentery. So if you start to see tumors that are causing so the mesentery normally is like a long sheet of tissue that you can open up and spread out. But when the tumors start growing on it, they start causing the mesentery to bunch up on itself and the bowel to kind of get all scrunched up on itself. And that's another area where they've seen a lot of complications after PIPAC in that setting. I think that probably the PIPAC causes too much scar tissue and it makes an impending bowel obstruction or the motility of the intestine worse with the cancer like that. So those right now are the major contraindications to getting PIPAC. So I hope that answered that question. I think this one's for you, Ariel.
That's my dad. Yeah, I would be amiss if I didn't also acknowledge that I still very much have a natural medicine protocol that I follow with a natural medicine practitioner, and not just taking herbs and foods that are supportive to my system, but moving my body frequently and connecting mentally, emotionally, spiritually with my healing, with my body, making movement and fitness a priority. So I'm still very much on my healing journey in that, I'm still on a protocol of sorts, just not chemotherapy or surgery. Yeah. at this time. So,
Yeah, I'm glad you brought that up too, because a lot of times people ask me, you know, is obviously, people want to be able to do something, right, to prevent the cancer from coming back, or I'm always being asked, what can I do to help myself, right? What can I eat? I really wish there was like a diet that we could put everybody on that would either prevent cancer, prevent it from coming back, or help treat it or shrink it or whatever. I know a lot of people ask me about sugar. We all know that cancers preferentially prefer sugar for their form of energy. And some people actually go to an extreme to try to cut all the sugar out of their diet, which also isn't very safe, as you probably know. Your brain and your heart also preferentially prefer sugar for their sources of energy. So even if you cut out all the sugar in your diet, your body has to maintain a blood sugar level within a normal range so that your brain is perfused, so your brain is happy, your heart is happy. And the way your body's going to get that sugar, if you don't give it some sugar, is by breaking down muscle. So you
mhm.
just have to be cautious about that. So what I will tell people is, don't try to cut out all the sugar, because if you do, your body's going to change in a way that's actually going to start breaking down muscle to provide the sugar that it needs. But you can avoid the super concentrated sweets. You can limit the sugar as much as you want, but don't try to cut it out altogether. And then obviously not smoking if you don't, not drinking if you don't, if you can cut those things back. Those are healthy things that you can do to help. But the one thing that and there's not a whole lot of literature on this, but it's there, is that if you're getting chemotherapy, exercise can actually help, like, what's the word, synergize with the chemotherapy. So there's actually been a number of studies that have shown that exercise while you're getting chemotherapy actually seem to improve the efficacy of the chemotherapy. And like you said, Ariel, I think it's a huge part of your healing process. So, and it doesn't have to be excessive. It's just getting out and walking or running if you like to do that, swimming or hiking, just moving, right? Finding something that you enjoy doing, carving out that time for you, making that part of your healing journey. And I think there's a lot that we don't know about the mind, spirit, body connection that is real. I mean, I have definitely witnessed that in my practice over the years. And I think it's real, and I just don't think we know enough about it, and how best to tap into it. Your thoughts on that?
Yeah, yeah. I'm of the belief that our bodies are meant to be healthy, and every cell in our body wants to work together towards maintaining the health of the whole. And if we provide it with the resources that we know it needs on the cellular level, then I'm of the belief that our bodies are leaning in the direction of healing. And that's a really different thought from like, I was diagnosed with this cancer and now it's taking over my body and it's out to get me. And I'm just like at the whim of these, chemotherapy agents and what people think ought to be done to me to heal myself versus this inner knowing of, I know what my body needs to feel well. I know when I feel well. I know what that feels like and how I need to eat and move and what it feels like when I'm feeling vital and healthy. And so I seek out food and practices that help me to find that feeling in myself. And that is very real. And you know how good you feel when you don't feel well. All you want to do is get back to, if I can just get out of pain, if I can just get to the point where I'm not having to be chained to the bathroom. I can actually walk around the block without worrying about needing to put on a diaper to go walk around. Like all of those things were things that I experienced on this journey. Just if I could just get past this pain, if I could just get past this challenge. And then sometimes we forget that when we're, feeling good, our every cell in our body is working together to try to maintain that health and wholeness. And that's going to be individual based on the person. And so I think connecting with healers, practitioners, doctors who resonate with your understanding of your body and help to empower you to know what's best for yourself. We call it practicing medicine because it's a practice and because we have to take it as it comes. And especially in these uncharted territories, it has to be a collaborative experience, I think, in order to be the most effective. So I think just empowering patients to know, like, you do know what's best for yourself, and you don't need a medical degree to connect with your own body and know what's best for your own body. And so just, I think finding practitioners and doctors like yourself who empower that in their patients, I think is so important.
I think that's incredibly important. I'm glad you brought that up. I think one thing that I would add to that, another aspect that I think gets overlooked, and especially in our society, where mental health still has kind of a negative stigma, and we're supposed to be able to tough it through this, is that is seeking help for depression or anxiety when you get this cancer diagnosis. You have never been, most people probably never been in this situation. It is life altering, and therapists and counselors can really be helpful. So finding either a community of support like you have with PMP Pals, or through ACPMP and through symposia like this, or obviously hopefully with your oncologist, but obviously they're going to be focused on something a little bit different. And so either meeting with somebody from a palliative care team or a therapist, and there are some therapists who do specialize specifically in helping people deal with a cancer diagnosis, can be really helpful and really powerful. And I would strongly recommend it if anybody is struggling with that, or has any questions. Just like you said, get the help that you need, get the support that you need. People may think like, oh, what's a therapist going to do for me? But therapy, like that kind of therapy, and being able to talk to somebody, and they have lots of, like, what one of my colleagues call ninja mind tricks, different types of therapies that can be really helpful in dealing with these kinds of situations that, like I said, most people have never faced before and feel alone, and they don't need to feel alone. Your thoughts on that?
Yeah, I'm glad that you mentioned that and just that idea of like n no one is going to be the center of your care. Like everyone has their specialty, and thank goodness they do. I mean, thank goodness you have this surgical specialty and know how to treat these cancers, and thank goodness that our oncologists know the ins and outs of chemotherapy, and that a psychotherapist knows how to engage with someone with who's just been diagnosed with a challenging diagnosis. And so someone who hasn't been trained in nutrition, if you're looking for nutrition advice, you go talk to someone who's been trained in nutrition, or you talk to if you're looking at surgery, you talk to a surgeon. Just remembering that there's no one out there who really is going to be the center of your care. And so you have to be that person and know that there's all of these aspects and components of my own health and what makes me feel healthy, the mental health, the physical health, spiritual health, and gathering your care team and choosing your care team wisely, and knowing that you are the center of your care team, and that in a lot of ways, then you are the full autonomous one making decisions about your body. And that's what it means to really take responsibility for your own healing, using the knowledge and the skills from all of the specialists around you, and then being the one to say, I choose this.
Hmm.
Even chemotherapy, I chose that. And surgery, I chose that. It wasn't done to me. It was a choice I made about my body to have done to me, thinking that it would be in my best interest. And So really gathering as many tools and resources as you can. I was part of the Huntsman's psilocybin clinical trial for folks who had a terminal diagnosis, and I was in that trial with many folks who would have never thought that they would try something like that, and who have never considered um, that type of mental health therapy, and how profound it was to hear their stories. And so I guess just, yeah, being open to that, something you might not know about or something you might have never thought you would be interested in, if it's starting to resonate, to be curious about all of the options out there. There are so many options out there. And so, yeah.
Great. Oh, good. I'm glad you were able to participate in that study. That's awesome.
Yeah.
Um, well, speaking of being the center of your care team, I know your folks are on the symposium, and I just want to give them a huge shout out because I remember when we first met, and they were right beside you the whole way. Just supporting you, but like you said, letting you make the decisions, but being there to help, because it is hard. It's hard to go through this alone, and you've been very lucky to have them. And I just wanted to acknowledge them as and part of your journey. So
Yeah,
yeah,
definitely. Yeah, I'm very, very fortunate to come from a medically minded family, and yeah, yeah. Yeah,
great.
I feel fortunate for that. And that is important too, to remember who is there for you and who is helpful, and who is not, and really lean into that. I know that I'm everyone is as lucky as I am to have super helpful friends and family members, or people who maybe want to help but don't know how to help. And so being able to delegate that and give people tasks, and whoever is the medical one in the family who's willing to help, lean on them, and seek out the resources, because there are so many wonderful people and organizations out there that are willing to help, if you just look and ask. Yeah.
Yeah, yeah. I think mentioning that everybody has good intentions, right? I think that's part of it too, because I know as soon as somebody gets a cancer diagnosis, everybody's telling them, try this, try that, you need to do this, you need that. And then people get offended if you don't do what they suggested, but there's no possible way you can do everything. And people are suggesting crazy things. And so just like you said, you have to you have to be the center. You have to make the choices yourself. You need to decide who you're going to listen to and who you're not. And just remember that everybody has good intentions. They're just trying to help, but some people just they're not helpful. And it's okay. But yeah. All right. Well, I think we are at the bottom of the hour. And Ariel, I want to thank you so much for coming and joining us and being a part of this and sharing your story. I know you said a lot of things that I'm sure were very helpful to a lot of people and that resonated with a lot of people. So thank you for taking the time to do this. I really appreciate it.
Yeah, thank you so much.
All
Yeah.
right, you're welcome. And I just want to give one more thank you to the ACPMP Research Foundation for supporting this symposium. And Margaret, I don't know if you want to say anything on behalf of the ACPMP Research Foundation, but please, everybody, remember all of this has been recorded. So if you want to go back and see any of it, you can do that. Please check out their website, and support them, and support the people that are trying to take advantage of their resources. And I think that's it. And we thank everybody for joining us today. Bye bye.